Good evening, everyone, and thank you for joining us tonight for yet another Chris O'Brien Lifehouse CPD series on eating disorders across different age groups. My name is Lydia Koenig. I'm CPD Program Officer here at Central and Eastern Sydney PHN, and working with us tonight, my colleague from CPD, Christina Parktown. Before we begin, I would like to start by acknowledging the traditional custodians and sovereign people of the land across which we work. I recognise the continuing connection to land, water and community, and pay respect to elders past, present and emerging. I'd also like to extend the respect to Aboriginal and Torres Strait Islander peoples joining us tonight. Now I would like to introduce our facilitator for tonight, local GP, Dr. Evelina Vincenzo, who is member of GP Education Advisory Committee for Inner West region. Thank you very much, Evelina.
Thank you, Lydia. Thank you, everybody, for joining us on this Wednesday evening. I've got the pleasure, first of all, to introduce the speakers for this evening. There are a few, so bear with me, but I'd like to welcome, first of all, we have Tammy Shapiro. She's the Reviews Project Officer and works for HealthPathways, and will be giving us an update this evening and available to take any questions after that. Further to that, the main speakers this evening, we have Dr. Anna Tai. She's a GP VMO with RPA Virtual. She also works as a GP in the community. She's a medical clinical lead for VE Connect at RPA Virtual, assisting with triage, intake and service navigation for clinicians looking after patients with eating disorders. I'd also like to welcome this evening Mars Kim, who is the Eating Disorder Coordinator and a Dietitian working at the Sydney Local Health District as the coordinator, and has been doing this role since 2017. Prior to this, he has over 10 years of clinical experience working as a dietitian in the tertiary acute and specialist hospitals. He's also a biostatistician, currently completing his PhD, and is involved in a number of research projects in SLHD and in collaboration and key internal external stakeholders. I'd also like to welcome Joe Williams, who's the Eating Disorders Program Lead, Clinical Psychologist, as well as the Eating Disorder Coordinator, the Mental Health Services at South Eastern Sydney Local Health District. As Lydia said earlier, they're very open to taking questions throughout this evening, so please use the Q&A function as we go along, and all of us are keeping an eye on those. But for now, I'd like to hand over to the team and look forward to hearing and learning more this evening. Thank you.
Thanks, Evelina. I think I'm first cab off the rank, so I might get started if that's all right, everyone. So thank you so much. Thank you for the introduction. Thanks, everyone, for joining us tonight. I'm just going to give a really quick overview about the Health Pathways Sydney and South Eastern Sydney programs. So as many of you will know, in the Central and Eastern Sydney PHN region, we have the pleasure of having not one, but two Health Pathway sites, which is awesome. And as many of you will know, that we've been running something called personal accounts now, or individual accounts, since April. So just a reminder, Health Pathways is absolutely free. That's for any healthcare professional working in the area. The only caveat is it's not for patients, but anyone working in healthcare is welcome to access it. So South Eastern Sydney Health Pathways aligns with the South Eastern Sydney Local Health District. So we're talking services such as Prince of Wales, Royal Hospital for Women, St Vincent's, and all the way down to St George and Sutherland in the southern part of our district. Health Pathways Sydney, which is the team that I work for, covers services in the Central Sydney region. So we're talking RPA, Concord, Canterbury and Balmain hospitals and associated community centres. If anyone is trying to madly get the QR codes now, please don't stress. These slides will be sent to attendees. So just a bit of an update on this thing that I mentioned, the personal accounts, individual logins. For those people who have used Health Pathways for years, you would have noticed that a couple of months ago, our old generic logins, so it was always Connected Healthcare, they no longer work. The only way to access Health Pathways now is via an individual account. You only need to register once, and you can use the same username password to then access multiple Health Pathways regions. If you want to, say, look at both Sydney and South Eastern Sydney, or if you want to look at Sydney North or any other Health Pathways region, you're able to do that with the same individual account instead of remembering the username and password for each individual region. Just to let everyone know that there's a lot of amazing features that are now available via the fact that we now have this new technology. I'll be talking about the CPD tracking system and smart search functions a little bit later on. And just to reassure that everyone's personal and usage data is absolutely secure. Our team, anyone working in the HealthPathways system, cannot see what individual users are looking at. We only get de-identified data to see things like page views. So to reassure, no personal data is recorded, and we are absolutely not looking or tracking at any usage. It's purely just for reporting data to see our utilization records. So we often get this question, given that, as I mentioned earlier, CESPN is a region that has 2 HealthPathways region. The question is, which one should I use? The answer is, well, you can use both. They're both open to you, but really it's going to come down to where is your patient accessing services? So if you've got a patient that, you know, needs to be seen, or you want to refer, say, to an RPA service, you want to be using the Sydney HealthPathway site. Whereas if you've got a patient and you want to refer them to, say, St Vincent's or St George, you're going to use the Southeastern Sydney site. The clinical content may vary slightly from the region to region. So even our eating disorders content, which we both have in both regions, we've both got slightly different content. And that's because the content we have is developed by local healthcare specialists together with local GPs. So there's always a local flavour variation. But it really just comes down to, where are your patients accessing services? There's no limitation. Like, just because you might be practicing in Randwick doesn't mean that you're barred from using HealthPathways Sydney, for example. They're open regardless of where you are, but just come to think of it in terms of, where's my patient going to be accessing services? Our main presenters tonight, my colleagues Mars and Anna, will be presenting models of care, mostly on the Sydney Local Health District models of care, but we've also got Joe, who's going to give us some wonderful information from the Southeastern Sydney perspective. Again, no mad rush to sort of copy this down, but in the slides you'll get an idea. This is some relevant content that we have in the area of eating disorders. So for Sydney, the main pathway we recommend is the Eating Disorders in Adults pathway, and this includes the SLHD GP tip sheet that Mars will go through shortly. We've also got various referral pages which take you through the different services that are available. Similarly, my colleagues in Southeastern Sydney, as you can see, slightly different variety there, but same sort of idea. So you've got your clinical pathways, which will take you through the assessment, management, and referral for the condition, and your referral pathways, which is really where you get your service information. So I mentioned earlier, one of the benefits of individual logins is what we call smart search. That's available as soon as you search something in the search bar, as you can see up on the screen there. One of the first things that will come up is try smart search, and then it'll list various topics depending on what you've searched. It will also show you exactly which section, whatever that keyword is mentioned. So it's designed to help you find content quicker than the previous search function was available to. Just a caveat here that the search engine still isn't as powerful as something like Google, so correct spelling is very important in this regard. CPD reporting is something we're really excited about. That was part of the infrastructure to release individual logins. So anyone who's got an individual account, HealthPathways will automatically be logging the amount of time you've spent looking at content pages, which you can then use to create your own personalized CPD report. You can add your own reflection to talk about what you learnt whilst looking at the pathway, and then you can upload that report based on a certain time period and use that to report to whichever reporting body you use. So this isn't just for GPs, this is for any healthcare professional that is required to maintain CPD to keep their registration. So here's just a quick summary of how it can be accessed. I'm not going to go into a lot of detail here because I really want to save time for the fantastic presentations that are here tonight. Just a reminder that these slides will be sent out to attendees so you can trial that. And if anyone has any issues at any point, our contact details for both teams are also listed on these slides. And just a reminder that every single pathway, even our homepage, has a send feedback button. So on any page, you are welcome to send feedback, whether it's good, bad, something missing, something you'd like to see. We love to hear it. Feedback from end users is one of the most valuable ways we can keep our content up to date, and that is triaged on a daily basis by a member of one of the Health Pathways teams. So that's all from me for tonight.
Thank you, Tammy. As always, fantastic. And so now we are going to move up to our main presentation by Marc and Anna. Thank you very much.
I'd also like to acknowledge the traditional owners of the land which we're all meeting on. I'm on Gadigal land at the moment. Normally at this time weekday I'd be at home in Darug land, but I'm here on Gadigal land today at this time. And I'd like to pay my respects to elders past, present, and emerging, and anyone joining us today. Also like to acknowledge lived experience and people with lived experience with eating disorders and mental illness, the experience of their carers, families, and supporters as well. Also like to just more of a from a safety point of view, there could be anyone in the audience or anyone here with lived experience themselves or someone knows someone. So please, if there's anything that's triggering or you're not feeling too well, please take care of yourself, and obviously more than welcome to leave at any time for self-care. Alrighty, so the main things that Anna and I are hoping to go through today are these sort of objectives here, and sort of going through a stepwise process around understanding the illness, identification and screening, then moving into assessment and management, some of the challenges of treatment in terms of treatment for people with eating disorders, looking at the spectrum of services and care and what available supports there are in the public health system. And I guess generally what, the way that I'm hoping to facilitate today in a discussion, Anna and I will take turns obviously talking, but I'm hoping to have a very highly interactive session with everyone. We don't have a lot of slides, I guess, in the context of 90 minutes or so. And we have about 4 case studies, and we try to sort of introduce a case study for each topic as a point of, I guess, in a way, storytelling. And to look at the practical relevance and to help with understanding the topics we're talking about. So please use the Q&A function throughout. Anna and I, and we're all happy to answer questions as we go. There's no such thing as interrupting. Happy to answer questions as we go. So yeah, please pop it in, even if it's kind of a retrospective question from a topic a little bit before that you may have thought of. Happy to answer them as we go, or if we need to come back and answer questions, happy to do that as well. So that's kind of how we're hoping today will go. But obviously, as always, we'll see how things go and then run with it. So just going into the next slide and the next slide. Sorry, we've always got these title pages. So just wanted to start with case study 1. Everyone else is doing it. I kind of called it. And just to let you know, none of these are real patients. Obviously, I haven't identified anyone anyway, but these are just very common examples over the years I've worked in eating disorders that we've come across. Just try and introduce some of the topics as we go. So this one is a 15-year-old AB, identified as female, currently in high school, concerned about body image and weight. Past few years has attempted dieting without success. Presents with a drop from BMI percentile of 50th to just under 25th percentile over the past 4 to 6 months. Presents to see GP due to difficulty concentrating with increasing fatigue. And they report removal of junk foods in their diet and exercising more, but no real different to her peers, as they're all trying different diets to stay thin or lose weight. We might move on, and then feel free to ask as we go. Anyway, if something comes to you later, go for it. Ask a question in the Q&A. So we do have a little summary slide, next here. And so really this is just to introduce things and to say that this person doesn't necessarily have an eating disorder, but it's a very common presentation and they may have an eating disorder. I can see a question. Thank you. How would you start the question? So I think we do, I think anywhere along the lines where, and we will go through this a little bit more in the identify screen section, but sort of a general tip that I think is helpful is anywhere you see a factor or a sign that you might feel that is related to an eating disorder, not necessarily mean they have an eating disorder, but dieting, for example, worried about weight, things like that, it's kind of an opportunity to ask a little bit more around that. So they're questions that you're already asking, but just be a little bit curious around, when you say, you're dieting, and what does that look like? Could be something along those lines. Or when you say, you need to lose weight, are others saying that you're too thin already, but you still feel like you're, too large, something along those lines, being a little bit curious. Again, some of this is covered in the screening, so hopefully that covers it there a little bit more as well. But hopefully that answers your question.
Well, something I was going to add as well, I think from a general practice perspective, is that in this age group, they might not always come in on their own, right? They might be with a parent or whatnot. So I think it's that case of, if we've got an inkling about how do we as GPs make sure that the patient is in an environment where they're comfortable to open up about it as well, I think. Perhaps arranging a further appointment on their own, etc. Yeah.
Yeah, absolutely. Absolutely. And sometimes what we do in some of our clinics, in multidisciplinary clinics, we've had sometimes 16, 17-year-olds. The clinics aren't thinking about adult-based, but we have 16, 17-year-olds come in with their parents. We might do a quick check-in with the parent and say, what are your thoughts on that? After the patient's had a chance to report on things. And I think that's another way to do it. But yeah, I agree as well, totally. If we need to make more appointments and a lot of the times, and we talk a bit about this in screening, you may need a couple of appointments to nut it out. You might not get it in the first time. And you may need to build the rapport, get a few more questions. They might reveal a few more things that are a bit more specific in follow-up appointments. Yeah.
Yeah, I think one of the things in GP is we have to be mindful that the appointments are not that long. So it's how do we adapt around that? But yeah, thank you.
Yeah, definitely. So yeah, I think I've covered a lot of this here. But again, the main thing here is that it is difficult sometimes to identify someone with an eating disorder, because there are a lot of people doing a lot of these things that don't necessarily have an eating disorder. There's a lot of overlap. So dieting and wanting to lose weight, things like that. It's opportunity to ask a few more questions, but again, we'll go through the specifics around that a bit more with the screening section. But the main point with here is that it's hard sometimes, and there's commonalities in terms of presentation. So next slide. So that just introduces some of these kind of context slides. And again, being a stats person, I tend to talk too much about data, so I won't. But the main thing I guess I just wanted to get across is that there's a lot of people in Australia with an eating disorder. 4% point prevalence, it's gone up a little bit, a touch to over 1.1 million when you look at it from a point prevalence point of view. Again, that's sort of a diagnostic breakdown pie graph on the side there. A lot of people often tend to think of eating disorders, anorexia nervosa, but it's actually, quite a small part of the pie, and eating disorder is much broader than that. We do have one diagnostic slide coming up at some point, but it's just to sort of provide some epidemiological context to this, and that there are a lot of people. And to be honest, a lot of these are very underreporting, given that ambivalence and avoiding treatment is part of the illness. A lot of the ways we survey or find out about people having an eating disorder is very underreported. So I'd say this is probably a very conservative estimate, and I've seen other papers quoting up to 15 to 16% as well. So it really depends how you collect the data, and it's often underreported. And then the only other point is that it does come with, particularly anorexia nervosa, comes with a lot of comorbidities, and they can have a high mortality rate. Some papers, highest mortality rate. I think the Deloitte study, the latest one, is second highest after substance and alcohol abuse disorders. So just to sort of say, it is a serious illness, and there are serious consequences that can happen. And obviously, getting in early and treating people is helpful. Next slide. I just click one more time for me. There should be I'll try to get rid of animations, but I think there's an animation on this one. But I'm using inpatient data just to show trend. And so again, my main point of this graphic from 2011 to 2023 in this one is this increasing trend that we're seeing. Some of it's based on identification, some of it's based on pathways that have opened up and services that we're looking at. but we are seeing general increasing trend. And again, I'm using inpatient data to demonstrate that, because the inpatient data tends to be a little bit more accurate, have a bit more information on there. So again, it's just to say that, you know, we are seeing an increase in presentations. It is multifactorial, but that's kind of the trend we're seeing at the moment. Next slide. And last context slide, some of the things that just gonna tick off. But we do have an eating disorder service plan, and the main point I guess I wanted to get across is, you know, there's a lot of pages here, and it's kind of, you know, as eating disorder coordinators, our bread and butter, so I won't bore you with the details on this one, but essentially my point with this slide is around, you know, that, you know, we are looking at this holistically across the state. There's an eating disorder coordinator in each district, doing our best to implement the service plan, which is essentially about opening up referral and clinical pathways and ensuring that we have equitable and you know, service access for people with eating disorders, their families and carers, integrating into the services and collaborating with services, not just, you know, within the public health system, but, you know, we have key external stakeholders. I work with you know, PHN and HealthPathways and, you know, Headspace and NGOs and lots of different services, as a lot of us do as coordinators. And then obviously with you know, alongside all of that is building workforce capacity, training, research evaluation. I can see a question there. Consultation process for the review of these plans. So at the moment, there's an evaluation where that the ministry have conducted on the eating disorder service plan. And so that's been completed, and we're waiting for the final, you know, sort of, I guess, the publication of that. So there'll be a review of that, the current service plans that have gone through, and where we're up to and what's happening. And then there'll be a process of where there's writing, there'll be input from key stakeholders in the writing process, which will then be reviewed, and there'll be multiple tiered layers of reviews. Again, I'm not the one doing it, so it's I don't know the exact details. Inside Out Institute writes it, and Ministry of Health, in collaboration with Ministry of Health. But it generally goes along the lines of someone writing it at Inside Out in collaboration as a group. And then there'll be sort of initial feedback from people who are working in the space, and there'll be sort of review and feedback that sort of starts to broaden out over time, with edits along the way with the document. So that's the general kind of idea of how that consultation will work. So it will be quite broad. At some point, it'll go to districts, it'll go to our, you know, external partners. You know, I'm sure primary care, private services, there'll be consultation around that. Okay, next slide. So yeah, another discussion point here. Why do people have eating disorders? So again, feel free to throw your questions into the Q&A. Well, we've got one. Thank you. I was going to break my silence soon. Are you seeing an increase of ARFID and neurodivergence? Yes, ARFID definitely. Neurodivergence, I don't have hard data on, or, you know, I guess anecdotally we are seeing more and more. ARFID, I guess, you know, being a new-ish diagnosis in the grand scheme of things, what we've tended to see is that there's a lot of people that have had ARFID, but sort of sitting under another umbrella, like IBS, or feeding clinics and various other places, and it's sort of never really diagnosed. Again, being a new-ish diagnosis in the grand scheme of things, I think even research papers coming out, you know, it's taken a while. Neurodivergence, we're definitely seeing quite, you know, a lot of lots of comorbidities, but there's also a lot of neurodivergence that we will tend to see as well. We do have actually, we will have hard data soon. We just haven't written our paper yet. We do have an included study which has a neurodiverse and neurodivergence question in there, and we had surveyed, I think, 3,500 people, and hopefully we'll publish that soon. It has been presented at a couple of conferences, and we were looking at the prevalence in the LGBTQI plus trans community, but we did have questions around neurodivergence in there as well. So hopefully soon we'll let you know. I found a big connection with domestic violence and eating disorders. Is it just me, or have others also experienced this? Yeah, I don't have hard data. Again, I don't have any sort of data on that specifically, but we do see a lot of trauma, and that trauma can be from lots of different things. DV is one of them. I'm not sure if I'd say that DV is something I'd see more than other reasons or forms of trauma. So yeah, I'm not too sure if that's, there's definitely a connection. I'm not sure how big though. Low self-esteem, body image. Yes, definitely a huge risk factor for eating disorders, body image. And tends to be one that sticks around a bit longer. When we've done research and surveys, body image is, it's sort of, people we survey will say they have it and then they still have it later. Whereas vomiting, they kind of tried a bit, then might maybe not stop doing it, came back to it. But body image is a big one, high risk factor. And low self-esteem, definitely. Low self-worth, low self-esteem, something we see very often. And again, development of eating disorder is multifactorial, and it's a myriad of factors that lead to it. It's not going to be one or two things. But yeah, low self-esteem is one of them as well. I found that a lot of my patients with eating disorders, especially NS nervosa, have a trauma background. It has become a secondary coping strategy for trauma. How do we best deal with the underlying trauma alongside the eating disorder itself, especially given the ambivalence to get better? Yeah, great question and background. I think, yeah, definitely we see a lot of trauma. And sometimes, the eating disorder itself, in some ways, is sort of a vicious cycle in a way, causes a bit more trauma. I'd say the main thing there is the coping strategy and the control and loss of control. And eating disorder is one way they can try to regain that control. And again, it's not the only thing, but it's also a numbing mechanism as well for them when they've got trauma. When you're severely malnourished, it sort of numbs you out a lot. And so it's sort of it's definitely a coping strategy. And again, makes it very difficult. And that's why they don't want to let it go. It's helpful for them. There are positives to it from the patient's perspective. We worry as a clinician of knowing the adverse consequences, but there are a lot of positives for the patient as well. And that's why it's the ambivalence is part of the illness as well there. Bodily expressions, somatic symptoms of underlying mental health stresses and triggers. Yeah, definitely there's somatic symptoms that we see. ARFID gastro is one example. Sorry, I kind of, it's an area I find interesting, so I sort of bring that up. But I think we do see a lot of symptoms due to stressors, things like fibromyalgia and pain and discomfort in all sorts of different ways. Is something that we definitely see. To what extent do intra-family issues contribute to eating disorders as a way of coping with issues out of the control, especially with associated depression, anxiety? I think you'll see papers that say, it's not the family's fault. And that sort of a thing. I think it's a bit that's a bit simplified. I think it's multifactorial. I think there's a bit of a chicken or the egg thing going on there as well. There could be some things that are family related, not blaming the family, but there could be some familial reasons for whatever's happening or the trauma that they have or whatever it may be. And then it's a bit of a vicious cycle. And family can't cope, or it makes it a bit worse, that sort of thing. So there are family factors, I think, that are important. And I wouldn't say, based on the research papers, it's not the family's fault. It's a little bit simplified. So I do think there's family factors.
If I can jump in, Mars, one way I like to think about it is that there's vulnerabilities for families, and sometimes there are protective elements and then vulnerabilities. So, if there are fragmented families and systems that are struggling, any eating disorder coming into that system, it just reduces the resources that family might have to fight the eating disorder or to overcome those challenges. But as well, there's a huge genetic component to eating disorders. So that can also be a factor where we see multi-generational eating disorders impacting the family tree.
Yeah, definitely. Thanks so much for that. Which leads on nicely to the summary slide after. Because at the top here, we've got eating disorders is complex and is multifactorial: genetic, biological, psychological, sociocultural factors. So yeah, we've covered a lot of this. As I said, it's good to have these Q&A discussions, I think, because I can have all these slides and go through a list for you guys, but we end up generating all of this from discussion, which is great. So I think we talked about all this, but just again, really quickly, coping mechanism, numbing emotions, sense of accomplishment, feeling control, and forms part of someone's identity. They're kind of this isn't an exhaustive list, but this is kind of my top 5 in terms of the functions of an eating disorder. But I think the important thing from my point of view and take home, and also as a clinician, that I continue to remind myself with, sometimes when you see a patient and the complexity, and it's very challenging to work in this space, is that the person has an eating disorder for a reason. It serves them a purpose. There is a function that the eating disorder plays in their lives. It has benefited them in a lot of different ways. Again, as a clinician, we tend to see some of the adverse consequences more than the others, but for the person themselves, it has been all of these things listed here. And when we say we want to help you, with your eating disorder, they will often interpret that as, you're taking away my coping mechanism. This is the only way that I feel in control. It's the only thing I've accomplished in my life. So they're the sort of internal dialogues that will be happening when we're saying, coming from a good place, we want to help you with this eating disorder. The reason why they say, no, please go away, or don't worry about it, is that's what they'll be feeling or thinking about. It's the functions of the eating disorder serves for them and the benefits for them. Next slide. So diagnostic slide here. So I guess DSM-5, we've got the 8 diagnoses there: anorexia nervosa, bulimia nervosa, binge eating disorder, ARFID, avoidant restrictive food intake disorder, OSFED, UFED, PICA, rumination disorder. I won't go through all of these ones, obviously in detail. You can read about those, in the DSM-5. If you're bored one day, you can whip out the DSM-5 and have a read. But also there's other resources out there as well. But again, the main thing I think with diagnostics for me is that eating disorder diagnosis is transdiagnostic. And I always see eating disorder diagnoses as a continuum. And we have this great big long continuum. You sort of have disordered eating over here and, diagnosis somewhere along that continuum. People can go from one diagnosis to another. I have actually seen a patient many years ago, a couple of patients actually, that had gone from avoidant restrictive food intake to binge eating disorder to bulimia nervosa to anorexia nervosa over a few years. I just happened to be working in that. I was working in a generalist space, but I happened to have seen that patient in different generalist settings, presenting with these different things, like in gastro and then respiratory and somewhere else. And so it's been interesting to see that, but it can happen. And so for me, again, it's that continuum. And even if they're not diagnostic, I kind of think of it as someone's got high risk factors, they've got very disordered eating and challenges. I do think trying to jump in early if we can, and you can detect it, is a good thing. They may not be diagnostic in terms of DSM-5, but they may be pretty close and likely leaning towards that. So that's kind of my take on it. Obviously, I'm not a psychiatrist or a clinical psychologist, but that's kind of my sort of overview in terms of diagnoses. And again, just to end this section on that, full recovery is possible. Again, if we look at research, you're going to see numbers that range from 30 to 70%. The way I like to look at it is that, recovery is possible in everyone. It just depends on what that recovery looks like. Recovery looks different for every person. It may not be a BMI of 20 to 25, per se. Maybe quality of life based or whatever it is. But in my view, recovery is possible in 100% of people. And it's just about individualizing what that recovery looks like. So that's kind of my take on it. Some people might say I'm being wishful thinking, but that's how I think of it. But I think it's really important that we do know that definitely recovery is possible by any, whatever definition we use. But yeah. Just got a question here. What is the difference between anorexia nervosa, binge purge subtype versus bulimia nervosa? Good question. I'm not the best at going through this kind of detail, but
I can jump in. The only difference is weight, really, when it comes to anorexia nervosa with binge purge subtype and bulimia nervosa, is they both may have the binge purge cycles, but the distinguishing feature is in anorexia nervosa, the individual is underweight.
Yeah, great, thank you. And then there's nuances in between that makes it really challenging sometimes with atypical anorexia nervosa and lots of things. And I have seen in the notes quite often, and understandably confusing, is anorexia nervosa and bulimia nervosa. They usually don't have both. Usually when I read that, I'm thinking anorexia nervosa binge purge subtype. But yeah, no, thanks, Joe, for that. Alrighty, next slide. So yeah, so that's that section on understanding illness. This section's on more around identification and screening. So again, only a few quick slides and then we'll go straight into the case study. Next slide. Yep. So this is, I haven't copyrighted this, but ISAM is, I just made that up. I like doing acronyms. So that's just the Mars thing. It's not an official thing, just to let you know, ISAM. But again, we often talk about screening. I like to think of it as there's one step before screening, which is identifying or looking at clues that someone comes in. Because often people come through, they won't come in to say, hey, can you please help me with my eating disorder? They'll come in and say, I've got pain, I've got fatigue, I've got all these other things. Please help me with that. And so I think that identify step's really important before we launch into screening or to even know to screen. So I think that's kind of my sort of stepwise thinking process around this. Next slide. So in terms of identify, and this is in our GP tip sheet that we have in the first sort of box. And these are some of the early warning signs. So weights obviously is a big one. And it can be sort of a lot of, it could be weight loss, but also, a lot of weight gain, like binge eating disorder and other eating disorders, not just necessarily anorexia nervosa. Body image disturbance, preoccupation with food, weight and shape is usually a big one. Again, dieting is very common, but it's sort of the extent to it. And then in the context of lots of other things. Menstruation, fertility difficulties, loss of sexual interests, gastrointestinal problems. Gastrointestinal problems is a big one. That actually comes up quite often. And when I've looked at emergency data, top 5 presentations are abdominal discomfort or abdominal gastro-related issues, which is really interesting. Some of it can be explained if it's anorexia nervosa due to gastric atrophy, and they sort of have delayed gastric emptying and feel discomfort. But that's kind of also related to, sometimes anxiety or, mood and things like that too, where they just, they're a bit more hypersensitive and somatic symptoms around their gut. Tiredness, poor concentration, again, very common symptoms, but in the context of things, physical signs of starvation or repeated vomiting, children with poor growth. And any inconsistencies you see in the history, particularly around like food and weight or some of these other warning signs, if you see some inconsistencies like, oh, don't worry, I'm eating fine, but their BMI is like 14 and they're dropping weight, and then they give you this, as a dietitian, sometimes see perfect diet history and just go, wow, that's, I wouldn't say wow, sorry, but, like that's interesting. And again, it's a point of curiosity, I think, and something you can explore a little bit more. So there's some signs that you can look out for in terms of identifying. Again, it's more of an identify step. So none of these as on their own is going to be, they've got an eating disorder. It's just more of something to be aware of. Next slide. I've got 2 questionnaires that I'll put up here. The first one is SCOFF, which is a validated questionnaire, and yes to 2 or more of these questions. And the case study goes through these questions in more detail. So I won't go through this slide in detail, but there are 5 questions, 2 or more. Yes to 2 or more of these screens you in as potentially having an eating disorder. It's a screening tool, so it's not perfect. And people will be screened in that don't have an eating disorder as well, but there's no perfect screening tool. So I'll go through that with the case study in a little bit more detail. And the next slide has the Inside Out screening tool, which is also validated now, has been validated for a few years now, I think. Currently trying to validate it in the perinatal space. So hopefully we can get that done. I think we've got 100 so far in terms of surveys completed. But again, it's very similar kinds of questions. This is available on the website on Inside Out, so it's kind of easy to use that way. You can just click through, with the patient can do it themselves, or you can click through with them as well, if you wanted to. When you go launch into Inside Out website, they'll have I'm here for myself. If you click on that, you'll go straight into the screener. And then it's graded as sort of a Likert scale of 5 for each one, and it's got its own algorithm, and it'll just spit out an answer for you. But the way I look at screening with these questions, again, with my research hat on, I think, oh, technically from a research point of view, you ask these questions as it is in terms of validation. But you know, in terms of in clinical practice and in clinical space, it's a bit awkward sometimes to ask exactly these questions exactly as they are. And so I think it's important to try and weave through, and that's what this case study hopefully presents. So I've got some interactions here, but I'll just go through the case study here quickly with you. So this person is I've titled, I just need some help with fatigue. So a 22-year-old MS lives by themselves, has an office job in a small company, have concerns about body image and weight. Past few years, they've attempted dieting without success, is how they're reporting it. MS presents with a drop from BMI of 23 to 19 in the past 6 to 8 months. They present to the GP due to difficulty concentrating with increasing fatigue. MS reports being happy with their weight and has been cutting out junk foods and exercising more. They're starting to feel lethargic. They have to keep going with their 2 hours a day. MS mostly eats by themselves, often skipping lunch at work. MS is happy about the weight loss, and that was a goal to start with, but wants help with the strategies around lethargy and how they can continue to exercise more. So I think the first step is identify. So I think there's a couple of things early on. There's a few things there, but I've just highlighted this bit around body image, weight. And the first question in this, I'm just using a SCOF screening tool here, but first question, they're not making themselves feel sick and vomiting and feeling uncomfortably full. So that's out, that's a no. You could ask about that if you wanted to, but there is a few more sort of signs here. Did anyone want to chime in before I reveal the answers? Or any thoughts? Or any questions in general around screening? And yes, the 6.35 kilos is a weird one, but it's 1 stone because it was in UK, so hence it's 6.35. If you get 6.1 or 6.5, that's okay. It's not an exact science. Any other questions about screening? I'm just thinking, what was the question before? Coming back to, how do we start? I think was one of the questions earlier on. So my answer to that again here, when we look at this scenario, is pick any thing that you're a bit worried about, and then you can ask a little bit more. So that Socratic, curious, exploratory questioning, I think, is really important. And again, I think the other thing, I think it was Dr. Vincenzo that asked around, 15 minutes, with a GP appointment is not a lot of time. So I think the other thing is the way, and again, this is just the way I look at it with screening, not just GPs, but also like, when you look at nurses on the ward, they've got Waterloo scores and they've got like 15 screening tools to do. That's a lot. And, it's not really practical. And so adding another screening tool for eating disorders, I think, is a bit tricky sometimes. And yes, we're all time poor. So I think identify is important because that will give you that initial clue. Who do I do screening tool for, or who do I want to ask a bit more about this? The other one is, I think, if you can integrate some of this into what you're already doing. If the patient's already reporting some of this, just expand a little bit on it. So I might just do the next animation, might sort of do the next two, one more. Yeah, just all, that's fine. So, I think any of these orange lines, so loss of control, feeling like you're too fat when others say you're thin, or food dominates your life. So it's kind of, the arrows are going to where those questions are kind of hitting a maybe yes, is an opportunity to ask a little bit more, explore a little bit more, be a bit curious. Or you're saying that you need. For me, one of the things that stands out is they're tired, but they still want to exercise 2 hours every day, and it's quite rigid, and it's quite sort of compulsive. So to me, that would be an aspect. And I know question 2 is sort of around eating, but there's sort of loss of control of the urges to exercise. So just pick one that you think you're fairly confident with. and be a little bit curious about it, ask a few more questions around it, which I know adding another question takes a bit more time, but weaving it into your practice, weaving it into some of the questions you already asked. You might already be asking about food, and you can throw a few food-related questions in there. Like, does it dominate do you feel like it dominates your life? Or you don't have to necessarily word it exactly that way, but do you feel like you've lost control of that? Is something that you know, how important is that to you? And just looking for little clues that way. And then you can kind of do a screen tool in your head, or if you have it in front of you somewhere, maybe you could sort of tick off yes, no, yes, no. So they're kind of some top tips I have. There's nothing else in the Q&A, so I think we're good. But yeah, if there's anything else that pops up for you, feel free to put it in the Q&A and we can answer questions as we go.
Also, just wanted to jump in and let people know that these screening tools are also available on HealthPathways, and it's also available on the Inside Out GP Hub. All right, so we'll keep going. So good evening, everyone. So Mars has covered the I and the S of ISAM. So I'll be focusing on the A and the M, the assessment and management of eating disorders. And I'm going to reference the GP tip sheet a little bit, which we created in collaboration with Inside Out and RPA Virtual. So this is what it looks like. So that's the front page. It was intended to be a tip sheet where the front would look like this, and then the back will look like that. And it's designed to be like a flip card that you can keep on your desk as a quick reference guide, especially if you don't see eating disorders, you know, every day, every week, and it's an infrequent thing. It's a good reminder of, you know, things, key features to ask for, to screen, you know, key features in the history and examination, which I'll go through in a moment. So this can also be found at the top of the eating disorder page in Sydney Health Pathways, and we'll be sharing this as a PDF resource after the webinar as well. So print it out and pop it somewhere on your desk. It's designed to be a quick reference guide to help you. Alrighty, so moving right along. So that's what the back of it will look like, and we'll go through this in a little bit more details shortly. So I thought I'll focus on each aspect of the assessment component. And here is, let's focus on history first. So here's a list of the key features to ask for or further explore on history taking. So I'm aware that there's mostly GPs on tonight's call, but I think there's some allied health joining us too. So this might be a bit more GP centric, but I'm sure it's just as relevant. So on history taking, there's a few things to consider. So we should be exploring the weight trajectory. So looking at the highest versus lowest weight, the weight loss, weight change velocity, you could say, over time, how quickly they've lost weight or gained weight. Looking at eating disorder symptoms. So whether they've got some body image disturbances, what the eating behaviors are like, exercise behaviors, and any compensatory behaviors. So we can ask about, you know, if there's any vomiting, excessive exercise, any medications abuse, including laxatives. Other things to look to ask for is about any signs of decompensation. So, you know, have you felt dizzy lately? Maybe that is their main presenting symptom: fatigue, feeling faint, or palpitations, which I'm sure we all see a lot in GP land. Asking about their menstrual history. So often a lot of them may present with, you know, I haven't had my periods for 12 months, please help. And obviously fatigue, poor memory and concentration. Obviously there's a psychological aspect as well. And, you know, we're all quite familiar with this and exploring any further, whether there's any concurrent psychological stressors, family stressors, yeah, and I guess leading to the genetics component, you know, exploring if there's a family history of this as well. So moving on. So the next component to look at is on examination, what to look out for. So I'll just expand a bit further here. So looking at key features on examination to look at. So looking at the patient's general appearance, looking at their skin, their hydration or fluid status, looking at their circulation, whether there's any evidence of self-harm on their, if there's any cutting or whatnot on their skin, parotids and dentition. So sometimes we do see parotid gland swelling in those with bulimia nervosa, where there's binge eating and then subsequent vomiting. You can sometimes see enlargement of the salivary glands. And obviously look at dentition for any oral decay that may be secondary to purging and vomiting. Obviously, recording all of the vital signs, the height, weights, and BMI, and to consider blind weighing if getting on the scales is distressing to the patient. It's good to record their temperature, two posturals, blood pressure, heart rate, and to consider doing a BSL and urine analysis as well, especially if they've been in starvation mode, and not to forget the ECG to do that too. Mental state exam is always helpful, and we often there's a list of, I've included a list of blood tests there that's also on the tip sheet. Often we're familiar with some certain bloods to order, but this is the full list to look at. So looking at potentially malnutrition or malabsorption, looking at their thyroid function, which sometimes may be the reason for some of their symptoms. And not to forget to consider a bone density scan as well if that hasn't been done, especially if they're presented with, fracture or fracture history or, just a low BMI alone. That's all allows them to access the Medicare rebates for a bone density scan as well. So moving on. So I just wanted to touch base quickly on the principles of management. So moving on to the screen. So eating disorders requires a multidisciplinary team-based approach. The GP is often the central, coordinator to their care. It's often the first port of, assessment and management, or identification, screening, assessment, and then management, and then referring on to psychologists and dietitian, preferably those who are eating disorder credentialed, and work in this space a lot, and plus or minus specialist input with psychiatry, pediatrics, or endocrinology, pending the other potential complications. It's also be important to assess the patient's motivation and their stage of change. Are they ready to engage in treatment, or they're ambivalent? That is a particularly important determinant of treatment success. Frequent medical monitoring. So the GP is well placed in the community to do this, and the bulk of this work does sit with the GP. And pending stability, you might need to set up weekly or sometimes even bi-weekly appointments, depending on the stability or instability. And I didn't include there, but I guess sometimes we need to include the family and their carer and empower them to support the patient in the community as well. And last and not least, not to forget to think about a safety plan or an escalation plan, which we'll allude to further in the talk about referral pathways and knowing how to escalate or where to escalate for help if need be. As GPs, sometimes we feel a bit isolated in practice, and it's important to know that there's always support out there. And we'll talk shortly about the where you can seek that support. So this is just a list of the things to consider when we see the patient frequently for medical monitoring, and the frequency of that will depend on the stability or instability. These are some parameters for when to worry and when to escalate to acute services like the hospital. Again, this list can be found on the tip sheet, which is on HealthPathways, and it's just some parameters. I guess we don't look at these parameters just in isolation. Often it's looked at a bit more holistically and in combination. So so often it's not just to think about medical escalation, but sometimes it's psychiatric acute concerns as well, which I've listed there. And finally, I just wanted to include a slide to draw people's attention to the MBS rebates that are available for eating disorder patients. I believe some of these eating disorder item numbers might be coming under review next month, so watch this space for changes. But this is what it looks like at the moment. So it's for those GPs with mental health training behind them, and you can access those item numbers. The eating disorder plan allows them to access up to 20 dietetic sessions and up to 40 psychological sessions in a 12-month period. These eating disorder plans must be reviewed every 12 months by the GP. And if it's more than 12 months, then you can bill the non-review number, so 90252 or the 253 number every 12 months. The review also needs to happen after every 10 psychology sessions as well, up to 3 per 12-month period. Now, just to, I guess, a disclaimer, that to be eligible for the eating disorder plan, you do need to have an EDEX score of more than 3. The survey, the EDEXQ survey is quite comprehensive. You can also find an interactive version on Inside Out. It calculates the scores as you put through your answers. So that can be quite helpful too, and that's in the Inside Out website. If the patient doesn't qualify for an eating disorder plan, maybe they're in that early stage where there's some disordered eating but not necessarily fulfilling a criteria for an eating disorder. There's also other options available, such as the GP chronic conditions management plan or the Better Access mental health care plan as well. I can just have a look at the chat box. Yeah, so OTs and social workers can also be included on the plan. But yeah, they have to be ED credentialed, I believe.
I think one thing, if it's okay to add, that I often notice comes up in conversation around the Medicare rebates is just providing education to consumers about the Medicare safety net. Because of how extensive the Medicare rebates are, we often find that consumers will more likely reach the Medicare safety net, and especially if somebody's on Centrelink. So we just find with the introduction of the eating disorder plan that tends to be a more key piece of information to deliver to patients accessing this service.
Yeah, that's a really good point, Joanna. I find, with patients who, especially those with complex eating disorders, and if there's a psychiatrist or a specialist involved, they often hit the safety net quite early on in the year, or especially if they're quite strategic and, stack a lot of their appointments in the first quarter of the year. They can reach the safety net by Easter, and then the rest of the year they get pretty much I think they only have to pay 20% of the gap for their consults for the rest of the year. So that can be quite helpful to know. Okay. I can see a question here in the chat box. How do we manage patients who refuse to go to inpatient hospital care, even if they meet the admission criteria, often because of traumatic experiences? So this does come up a lot in the public health system, and I think, Mars, I'll let you answer this question because you probably see a lot more of this ambivalence.
Yep, sorry, I clicked on something wrong here. Yeah, it is hard. I guess at RPA we do always try to balance the balance between engagement and not creating the experience to be making sure the experience isn't too traumatic for them when they come in. But obviously that's got to be on balance with medical safety and safety in general. And so it is quite tricky. Obviously, I'm talking more prevention in terms of hopefully each admission not being so traumatic they don't come back. I think when that's already happened, it is quite tricky. I mean, the way I look at it is, depends how unwell they are. If you have very serious concerns that the patient's life's at risk, then you may have to use Mental Health Act and call the ambulance, etc. If they run off and you're unable to, whatever happens, you can call the acute crisis team to go to the house with an ambulance. Again, not necessarily the easiest things to do, but when it gets really urgent, there's some of I'm just sort of starting from the most urgent scenarios here. There's some of the things that you have, that are options to you. But often when I have this conversation with some of our GPs, the thing that they will say to me is, yeah, but Mars, then I'll lose all my rapport with them, which is completely true. well, not always true, but can be often the case. And it is challenging. But again, I think it really depends on your clinical judgment around how worried you are in terms of that person's risk to self. And you may have to. Otherwise, I think it really depends on the district that you're in and how you, make that work. I think for us, I always encourage to have a chat with our endocrine team at RPA. And we do have a clinic kind of specifically designed for this. And so we'll assess them. Not every district will have that, or most districts don't have that, but there might be some other options that you could look at if it's that next tier down. Like if you don't think their life is imminently in danger, you may have a few extra steps that you could take. And so for us here, that would be that clinic. And we'll talk about access to services a bit later on. Joe, did you have any other thoughts from your district or your point of view on that?
I think just that it is really tricky. And I think it's hard to give a firm and fast response because we know that, there can be some people in early stages of their illness versus people who have had eating disorders for 30 plus years. And so there might be some differences across that span. But the general principles that I like to follow, especially in private practice and working across a team, including a GP, is it's best to have that conversation ahead of time. Versus when you're in that moment and having those agreed non-negotiables to say, look, I'm here for your safety. This is what we've defined is that criteria. We're following the medical admission guidelines criteria to say that this is the time to go to hospital. What we'll do is try and make that as straightforward as possible. We're going to call ahead to the emergency department and let them know that you're coming. In this situation with these concerns, my preference would be that you're able to go there by yourself. But if you're not able to, these are the steps that I'll take to ensure that you are safe and reviewed and get the care. And especially in the context where somebody is really struggling to implement changes or engage with the treatment team, they're on a trajectory of deterioration and struggling, that is often the really important boundary that you have to hold for that individual sometimes. And what we do see over time is that sometimes that does lead to ruptures in GP relationships, but also sometimes that's a really important message to say that your safety is the priority here, and I need to follow through on what I'm going to say, which is that we don't go beyond this boundary when it comes to your physical safety.
Yeah. Great, thanks for that. Hopefully that answers your question. It is very tricky. There's no perfect answer, but I always say I'm here to support if you need it. Feel free to give me a call. Or for us endocrine team, but it's tricky. I've had many conversations before with GPs of I don't want to lose all of my rapport and they'll never come back and see me again, and then that's risky for the patient too. So it is very tricky, and lots of things to consider in how we approach it. Okay, I'll whip through this section because I do want to spend. I think service is probably the most helpful thing for everyone. So I'll just whip through this really quickly, this section. It's only a few slides anyway. Just introducing this section with this person. I'm okay, don't worry about me. It's all good. 67-year-old with flu-like symptoms. I'll just go through this really quickly. The BMI has always been around 16, recently come down to 15. Difficulty with eating, poor appetite, difficulty with breathing, eating as well. They've got a respiratory infection. They'll given antibiotics. They've come back a little bit later, and the infection's gone. But they've lost another 1.5 kilos. Very tired, dizzy on standing. Again, you express that they need to eat more, and their weight's too low. But they're like, it's fine. Don't worry about it. Very hard sometimes, particularly with older, people that are older. They've had it for a long time. I'm assuming with this person has an eating disorder in the background, but never had treatment. You can see this kind of situation. Actually, I used to see this a lot in COPD, working in respiratory, maybe not as low as BMI 15, but some patients they don't necessarily have an eating disorder. They just got long-term shortness of breath and challenges. But assuming this person has an eating disorder, it is quite difficult because they're saying, no, I'm not worried, don't want to do it. It's fine, don't worry about me. So hopefully we can give you a few little tips here, and I'll whip through them. I'll just see if there's a question on here first. Some of the patients were told by psychologists that they have addictive personality. How common is drug and alcohol use? Yeah, it's pretty common. And I would say one of the most challenging comorbidities when you have eating disorder with drug and alcohol, they seesaw between eating disorder symptom and drug substance use. If I use alcohol as an example, really tricky, because the eating disorder service will go, oh no, they're drinking, we can't see them when they're drinking. And then the drug and alcohol service say, oh no, now their eating disorder symptoms have gone, quite severe, so now we can't see them. And sometimes I've seen patients swing between the symptoms within 2 months, and by the time you refer to one other service, the other service disengages, the person changes symptomatology, and then you're kind of stuck in a rock and a hard place. Very challenging from a service point of view, but also very challenging because the patient has two, in a way, coping strategies that have very adverse medical consequences and general, adverse consequences. So yeah, it is quite common. I might skip over this slide and just go into a couple of things so we can save some space for services. But key point slide here just on resistance, and we've covered a lot of this already anyway. Ambivalence, resistance, a core feature of the illness, and it is around a sort of balance between being empathic and firm at the same time. The only caveat I would say with this particular key point is we do see a lot of comorbidities these days with quite severe trauma, and you see the other way around, where you see people come in and say, I need to be admitted now. I've only had 500 calories every day for the last 4 weeks, but they've lost no weight, or they've lost a bit of weight. Or sometimes they really haven't eaten anything for 2 weeks. You do see that opposite spectrum in a way, but underlying all of that, obviously a lot going on there. So in some ways it's similar, but also very different, and it is very challenging in both kind of, both sides of it. Next slide. So this kind of, again, it's just a background thing just to sort of say, what you see on the surface is just what you see on the surface, and there's a lot underneath all of that. And it's just to sort of give that understanding. And again, with those two extreme examples, when someone's like, I need to be admitted, what's wrong with you? Like, obviously there's a lot going on there, and what you're seeing is just on the surface. Same with the person who's quite ambivalent and doesn't want any treatment or care. You can clearly see there's issues, adverse physical consequences or other parameters that you're seeing. And obviously that, you can see that, but for them, it's a protective mechanism at times. They're trying to protect their eating disorder. There's a lot going on underneath. So I use the iceberg model for lots of different things, but for this purpose, it's more about sort of what you see on the surface is just the surface, and there's a lot going on underneath. So next slide, and apologies for speeding through this, but I do want to save time for services, because I'm sure there'll be questions there. Again, this is not an exhaustive list. This is just kind of my, in a way, top 4 or so. And each one, you can sort of have a whole workshop on, really. Or maybe not on neutral tone and curiosity, but in general, there's a lot of these strategies you can have a whole workshop on. So it's just a really quick sort of few things. And I sort of, again, we covered all of this anyway. Our primary goal is really to maintain engagement as best we can. You want a patient to feel safe enough to return, building that therapeutic relationship and engagement. How we do that, and I think a part of that is maintaining a neutral tone and having a very curious approach to things, sort of a curious explorer. And again, these are all things that I'm sure you've heard of as well anyway. Rolling with resistance. It can be very challenging in eating disorders because, there's eating relationship is something that we all have. Relationship with food is something we all have. And when someone comes in and has a very disordered eating, poor relationship with food, it's very different to what we're used to. And so it can be very tricky sometimes. But the same principles apply with any patient we see. It's about rolling with resistance. When they say, no, don't worry about me, go away. What are you talking about? I don't want to talk about that right now. Just rolling with that resistance and validating their concerns. And to me, therapeutic stance is really important, and getting that balance right between empathy and firmness. When someone says, no, I don't want to do that, it's like, I can it's starting off with, I can see that's difficult for you, but it's really important that we look at some treatment options for XYZ reason. So getting that balance, I think, is really important. When you break that balance is when you start to get into a bit of trouble. Too much empathy, too much firmness, it can be problematic in a lot of ways. And again, coming back to that, what's on the surface and versus underneath. When someone with an eating disorder, they're in a constant struggle with their eating disorder. And if we're overly empathic with the eating disorder, when they come out and say, oh, I can't do this, it's too hard, that sort of thing. You go, oh, no, it's okay, don't worry about it, it's fine. That's actually more traumatizing for the patient because, what you're talking to, in a way, the eating disorder, and they're in a constant battle, against the illness, and we want to help them, not the eating disorder. So I think that's really important, trying to get that balance right. Not an easy thing to do. And then last thing around that, which I haven't listed on here, I just call the broken record technique. If they keep coming back to see you, that's a great sign. You may have to go through this a few times with them, but that's part and parcel of treatment for people with eating disorders. But it's trying not to lose patience, maintain that neutral tone and curiosity, and plugging away or chipping away is important, I think. What is the long-term effect of eating disorder on mental functioning, given that eating disorder significantly affects the microbiome? Is there an association with later dementia development? I'm not sure about later dementia development and the association. They do obviously have cognitive changes. We do talk about it with our starvation syndrome. And again, psychologists and psychiatrists are probably best answering this in terms of myelin sheath, and obviously they lose the fat stores, and their brain, that there are changes in the brain that occur. Again, starvation syndrome, we do a whole talk on it. It goes into this in more detail. Jo,
I have a recent example which demonstrated this really well with a 30-year-old female who had only had a 9-month history of her anorexia nervosa onset. She came into hospital after having a fall because of hypoglycemia, I think, and so had a brain MRI, and she had significant kind of neurological abnormalities after that period of starvation that were quite pronounced and had no previous issues. And so I guess they drew that even after a short period of time, we know that definitely the brain shrinks. There's a lot of kind of structural changes that we see. And then we also see it in terms of how somebody neurologically functions and a lot of rigidity. However, there's a big contrast in that we see some people during an inpatient admission who is studying and getting 90% or 95% on their exams, but in terms of their flexibility, they just have no capacity to kind of adapt and adjust or think big picture about their life and about their situation. So we see quite a contrast, but there's definitely a dramatic impact. And definitely when it comes to microbiome and gut functioning, like we see, as Mars mentioned earlier, quite dramatic changes across the board. But that's a good question about dementia. I haven't read much about that.
Yeah. I think a lot of the answers you might find in the Ansel-Keys starvation syndrome as well in general, because that went through, again, we could never replicate it because it's deliberately malnourishing people and studying them. But again, that's also why it's a study we still talk about to this day. So if you want to look up starvation syndrome, Ansel-Keys study, really interesting, covers a lot of the symptomatology and the rigidity Joe was talking about, and all the other myriad of symptoms that we see with starvation syndrome. Really interesting. To look at. Can be really helpful to acknowledge that some patients are fearful of recovery as they will lose their team or support. Yep. They feel the need to stay sick to get the care they need. It can be helpful to remind them that GPs are here for the long term. Even in completely recovery, there'll still be more for us to do. Yeah, no, I think absolutely. It is a long-term game. I think even in the inpatient setting, we talk about this all the time. We're looking at the long-term game here. Sometimes we might discharge them a little bit earlier. Sometimes the community teams get a little bit upset with the inpatient team, but clear communication helps with that, why we're doing it, and the supports are there, and all those sorts of things. But I think looking at the long-term big picture is really important as clinicians. And yeah, we'll talk a little bit about that with the service as well, I think. Yeah, okay, so we might flip over to the next. So this is the last section on services, which I was hoping to spend the most time on, but we've had great conversations. That's good. But starting with case study again, and then we'll have some sort of slides on services. So you may be familiar with this. This may bring up some things for you because it is a challenging scenario that we do quite see, more often than I would hope, in a way, because it's very challenging. So this is a 27-year-old atypical anorexia nervosa, not necessarily atypical actually. I'm not sure why I put that in there, but they've got comorbid BPD, depression, PTSD. Oh, that's why I put atypical in there. Comorbid BPD, and we're writing some guidelines. We're calling it atypical. But this person's, fluctuating from BMI 13 to 16. They go 2 weeks at a time without food. Sometimes they have had 7-8 admissions over the last 8 to 9 months. You just feel like there's no end in sight. Acute care services asked the GP to review as they stopped eating and drinking for 5 days. Their heart rate's 42, neutrophils 1.1. So they're kind of hovering on that sort of, do they need an admission? They've disengaged from everyone else. And I'm thinking GP here, but GP's sort of left with this patient sort of really unwell. What do we do? Really tricky. So I thought I'd introduce this service section around this, and I think we've kind of covered some of this already. Next slide. So I think, again, just in interest of time, I think the main concerns here is that the patient may not always be admitted when sent into emergency, and that's challenging for everyone. Feeling hopeless, given so many of the admissions, and heading for another admission yet again is the other thing that you can be concerned about. And then challenges with feeling like the only clinician involved left in care. So they're all very important concerns and things that we hear all the time. Some of the solutions to that, though, would be, I think we covered some of this already, which is being very clear with setting clear boundaries early on. I think Joe mentioned sort of talking about this early, talking to them about when we need to look at potentially a hospital or how that would look. And doing that in again, that balance of empathy and firmness. I think is important. If possible, finding an inpatient team that's allocated to eating disorder treatment and sort of maintaining a dialogue with them, I think is really important where you can. Again, I know everyone's time poor, but for us here, we found that really helpful in both ways. And also this concept and understanding that readmissions are actually part of a patient journey. There's other chronic illnesses that we look at where readmissions, we think of as part of it is, Crohn's disease, they have a flare. But in eating disorders, we sometimes think of it as, readmission, that's terrible. I mean, it is terrible. We don't want them to be unwell. We don't want an admission where possible, but sometimes it's necessary. It's not an evil thing. It's not a failure of treatment. It's a very severe illness, and people sometimes need an admission. It's not a linear trajectory of recovery. It's going to be ups and downs. So I think that's a really important concept. And it's important to maintain that collaboration and communication with the hospital team if you can. Again, acknowledging the time poorness we all have. And maintaining that hope is always important throughout the journey for remission recovery. Next slide. So that green box there is just a quote from a research paper actually from someone with a lived experience or living experience. And again, it just highlights how important that hope is. When they feel like everything, hope's gone and everything, what had endured for them was a belief that, my life was worth fighting for when others held hope for recovery for me. And I think it's really important. And I think it's just the way that we approach this, and it's a way that we word things and how we frame our conversations with patients when we see them. Admission, it's not the end of the world. It's not treatment failure. It's, we need to help you right now. Let's do this and let's work this out together. Let's work together on this. Sort of that kind of a dialogue. Maybe that's not the best way to do it, but that's the kind of thing you want to sort of be, having a conversation with about the patient. Next slide. I might skip over this. I might sort of go back to yourself, Anna, just with the more practical things. Yeah.
All right, so this is, I guess, drawn, referring back to the GP tip sheets. that we're looking at before. So this is on the flip side. So there are a few referral options depending on, I guess, disease severity, the location of where you work, but also where the patient lives. There's quite a lot of options here, and sometimes it's tricky to navigate, the system privately and publicly. And just letting you know that, the best placed person out there to help you is the local eating disorder coordinator, so such as Mars and Joanna. Every local health district in New South Wales has a nominated eating disorder coordinator, and so sometimes if you're feeling quite isolated or feeling a bit lost, they can be quite helpful, and their contact details will be shared on the final slide. So I guess just to work through this table, which I know looks a little bit busy. So I guess for those with mild to moderate illness, a lot of their care would be GP based, with ongoing medical monitoring as often as is indicated. In terms of some services that's available, for those that can afford private care, there are some clinics including Ramsay Northside, the Miller Clinic in Leichhardt. I think there's Body Matters and the practice in Lower North Shore as well. For those who are aged between 12 to 25, there is an eating disorder specific clinic at Headspace Camperdown that is GP led, and I believe there's a dietitian or a psychologist attached to that clinic as well. And I guess moving on down the table, so if the patient is deteriorating but not quite meeting that acute criteria, and you've exhausted all local services, including private clinicians, you can call RPA Virtual V Connect for assistance. So that's where I work. We can assist with the triage intake for referrals to the tertiary level Peter Beaumont service, which is based at RPA, but it is a tertiary statewide service. And if you're not sure, again, just to consult with your friendly local eating disorder coordinator. And obviously if you've got, acute concerns, then and meeting some of the parameters that we previously discussed, then they should be referred to the nearest ED for medical stabilisation or psych review. Moving along quickly, mindful of the time. I've just included a slide here about child and adolescents. Look, the pathways are currently under review. We don't encounter this cohort that often, but for those needing a step up in care, referrals can be made to CAMS, which is based at Rivendell, and there's a contact phone number there. This can also be found on HealthPathways again. And again, if you're not sure what to do, speak to Mars or Joanna for assistance in navigating that awkward age group sometimes, between as they hit 16, 17, 18, it's a bit tricky on where the appropriate place to go is. So this is mostly the services based in our local health district. Mars, I might let you talk about these clinics.
Yeah, just run through this really quickly. But just also to add, in terms of the acute side of things, for us, obviously if it's urgent, emergency department, but even in those moments as well, if you could give the endocrine team a call, that's really helpful. I think that's a really important step one. Or step two, if it's urgent. If it's not urgent, like super urgent, like ambulance emergency, if you can give them a call ahead of time, that'll be really helpful. And I think that verbal collateral history context, really important, because emergency, they come in and you see one point in time. And so the history that you provide makes a huge difference, but also it starts to build that sort of working relationship. And also endocrine put them on the expects list, and then that'll activate our pathways more consistently. Sometimes depends on who's on in emergency, and they might not follow our emergency procedures per se. So it's sort of not guarantees, but it sort of increases likelihood. So I think that's important. In terms of some of our services, as I mentioned, we do have a M-Med clinic is called, and it's specifically designed for these people deteriorating in the community medically, and also people that have gone into emergency that don't quite need to be admitted yet. And so if you give the endocrine team a call, for example, in that example, and they go, well, they're not quite, I don't know if they're quite needing an admission, but we'll book them into this clinic, and at least that can be offered, or they can give you advice on the phone. So it's really helpful that way, and hopefully you feel supported from that. And then the endocrine team also have their own separate eating disorder clinic with comorbidity for comorbid other medical comorbidities. I can't talk. And the referrals are the usual sort of specialist referral pathways that you follow with HealthLinks endocrinology. The recording for the slides will be on here. I won't be sending the slides through per se, because again, the way that I do this is quite interactive, and it's sort of missing that other 50% of the information. But the GP tip sheet has all this on there, or a lot of this on there. If there's any other information, I'm happy to have a look through if you wanted to email anyone, and then I can happy to send through extra information and resources.
And Mars, maybe as a suggestion, we could send through this slide just as a isolated slide, because it's got some important information on the bottom, especially in terms of how to access these clinics. So we can send, this as a resource after the webinar as well.
We can do that. And yeah, the wait time is like 1 to 2 weeks max. So that's the beauty of one of these clinics. This clinic is, we only see them 2 or 3 times usually. It is for sort of more immediate response. So the beauty of it is it's a combined endocrine CL psychiatry clinic. So we have both sides sitting there. Unheard of, medical and mental health sitting together. Who would have known? But we do that. But also because of the nature of how we run the clinic, roughly 2 to 3 times the max we see people. It's not a strict rule, but then that keeps things contained. And we always closed loop system. We always refer out where we can, or admit people if we need to. But yeah, 1 to 2 weeks usually max. So it's a fairly rapid response clinic.
And I guess I just wanted to add, sometimes it's helpful to have that early discussion with the endocrine team, because you can potentially avoid emergency, especially if the patient's ambivalent about going in, if they've had past experiences of being sent home after the GP has spent all this, energy trying to convince them to go in. So sometimes that can be seen in this clinic. And I think recently there was someone that was seen the next day after being referred, and then they were admitted, from the clinic to the ward, but it bypassed emergency altogether, which may be triggering for some. If you wanted to refer to this tertiary service, the point of call is via the Connect, whose number was on the previous slide, and letting people know that there is 3 arms. There's an inpatient arm, an outpatient arm, and then there's outreach. So for clinician support, if you need it.
And sorry, Joe, did you want to, I know we're over time, but Joe, did you want to quick Southeast? Yeah.
Very brief, because there isn't much.
Yeah.
But we have got a navigating adult eating disorder referrals slide that will go out to everyone, which talks through, I think, some of the similar pathways that you might explore, options in the community, but we have quite varied options in terms of our public services. We do also have some information on the Southeastern Sydney Local Health District website. When it comes to child and adolescent, all of our child and adolescent mental health services, which service up to or under 18, provide eating disorder treatment for young people with say more moderate to severe presentation, and we do also have outpatient clinics at our Sutherland Hospital and St George Hospital. So,
thanks for that.
But
yeah, no, thanks. And yeah, we do have this last slide on here. Just if you need information, I can send this around too. But I did want to thank everyone for having us. And it's been great to talk to everyone, and great questions and discussion. And again, it's a privilege to have these kind of conversations. So just wanted to thank everyone.
Thank you once again to our presenters and our facilitators, and thank you to everyone attending tonight.